thank you all for being here and being at our conference. My name is Carrie Torgerson, but I'm going to introduce our speaker. This is Dr. Bill Cosgrove, and he's a pediatrician in private practice in Murray. He's a zealot for vaccines, and for the past 30 years, he has been the chapter champion for all things concerning immunizations for the Utah chapter of the AAP. He serves on the Utah Scientific Vaccine Advisory Committee, the USIIS Steering Committee, and also serves on the Salt Lake County Board of Health. So we'll turn the time over to Dr. Cosgrove.
Thank you. Thank you. And I appreciate being here. I'm videoing this so that we can run it again. And I'm actually glad I'm going to do that, seeing how everybody at the audience is already a zealot about vaccines. So first, I'd just like to tell you about sort of the history. When I was first trained in 1980 to 83 at Primary Children's Hospital, essentially every night we'd lose a child to a Haemophilus influenza type B. And I thought that was just hospital stuff. There was 250 deaths that year, each of those years at the hospital. So it's about one a night. And it just tore at my soul. And so finally I graduated from residency and thought, okay, I don't have to see this again. In the first 2 years of my private practice, I lost 20 children to that one illness. And 2 years into practice, I thought, I got to get out of this work. This is too hard. It's just emotionally draining. It was eating up my soul. That was in 1985. And then they made the HIV vaccine, and that illness has disappeared from our horizon. And when that vaccine came out, I just about kissed the ground, because that enemy, my mortal enemy, was defeated. And so I've been a zealot for vaccines since, and I've essentially been to almost every meeting about vaccines in our state. As far as disclosure, the office I work at has contracts to do some post-licensure vaccine work. I've never worked with the HPV vaccine, so I don't have any conflicts there. We have stagnant vaccine HPV rates, and we end up leaving a whole cohort of our children vulnerable to these illnesses. And so I'm going to provide a bunch of information, both technical information about the virus, the vaccine, and the illnesses, but mostly I'm going to try to get to how do we communicate so that we can convince people to do this to protect their children. The objectives, I'm using the slide deck from the CDC. I would recommend that. It's called HPV, You Are the Key. It's available online, and it is got more information than any of us can stand. But we're going to define the importance of the vaccine, list the indications, provide useful information, and trying to help parents with the decision to vaccinate their children. First of all, the burden of this illness, and I want to get back to sort of basic concepts a little bit. There's, over 100 types of human papilloma virus, and for healthcare providers, we've all had or had family members who've had plantar warts. Okay, that's an HPV virus. And if you kind of think just what happened with that wart kind of gives you a sense of what we're dealing with. The wart virus enters a small break in the skin, and then it just sits there. It's dormant, it doesn't do much, it doesn't hurt, it's kind of just a nuisance. And if you're confident, if you wait, it goes away in a year to 2 years. But it just sits there. And you can do all the painful things and burn it off and cut it off and freeze it off, but mostly it comes back. And finally, when your immune system gets around to it in 2 years, you defeat that virus. Well, unfortunately, some of this virus class can lead to cancer, so that's why we're talking about this. So HPV 16 and 18 are the worst of the class. They cause most of the cancers. And that's why the people decided to invest in creating a vaccine. So essentially, this isn't for somebody else. This is all of us. The estimates now are 85% of adults will have encountered this virus in their lifetimes. So it isn't just those few promiscuous folks or just those high-risk folks. That's all of us. And so part of the stigma of this, of being a sexually transmitted illness, is a thing that we sort of have to work around and educate around, because essentially, if you're human and if you involve in any kind of human intimate activities, almost of any kind, you're going to be exposed, and your children are going to be exposed. So the numbers are awful. 79 million are currently infected. So again, I'm not going to name names, but it's everybody in this room. And the trouble is, these are asymptomatic, so you don't know you have it. So therefore, you can easily give it to your next loved one, and that's part of the problem here. And you may carry this virus for 2 years and give it to a series of loved ones. In terms of the numbers are staggering. These are just some of the subtypes of the HPV virus, but again, 250,000 people with genital warts and 11,000 with these are the number of essentially cancers. Genital warts, it's sort of hard to call that a cancer, but essentially it's worthy of thinking about it. And then oropharyngeal cancers are on the rise. Cervical cancers are slightly decreasing, but the total numbers are still increasing. So the average number of new cancers probably caused, and again, probably caused, some of these are not fully diagnosed. We don't exactly know by the time the cancer arrives whether or not HPV started, but the HPV is the main culprit in most of the cervical cancers and oropharyngeal cancers. Again, it's fairly recently that they've been fully diagnosed, and therefore the culprit, and those numbers are increasing. Probably because we're ascertaining it better. I'm going to flip through a lot of these things in kind of a hurry. So again, the HPV, the oropharyngeal cancers are increasing, and cervical cancers are slightly decreasing, but the numbers are still staggering. So worldwide, 500,000 new cases each year. Worldwide, there's an awful lot of deaths. In our country, at least the death rate is lower. And the other thing that we sort of have to realize in terms of a population risk is that a big chunk of the cancers that we're dealing with are women in still childbearing age. So where most of our other cancers hit adults after they've had their most productive time, after they've raised their children, after they've got their career online, even as most cancers occur after people are retirement age. A lot of these happen while people are still in their productive years. It hits essentially all races and genders, but there are some racial disparities. Our Hispanic neighbors are a little more at risk of both males and females as far as HPV cancers. Here's Utah. We have fairly low rates, lower rates than other areas of the country. Wyoming is one of the higher rates in the country. But again, this doesn't keep us safe. This doesn't protect us. And as we mentioned about age at diagnosis, other kinds of cancers, colon cancers, bladder cancers, tend to be out here. HPV cancers tend to be hit us earlier in our lives. And the cervical cancer, if you notice, cervical cancer is on the decline, where where is it? Oropharyngeal. The blue, actually, this is on the decline, but actually everything I read is that the recent illnesses, recent suggestions oropharyngeal cancers are on the increase. And it's expected by 2020 that oropharyngeal cancers are going to be higher than cervical cancers.
Well, that's age at diagnosis, so it's not actually an incidence.
Oh, thank you.
Yeah.
See, educated audience. Catch me.
Go up like that, for instance, but that's just age.
And these are males, and again, this slide from the CDC suggests that oropharyngeal cancers are decreasing, and yet I think everything I've read is that there's increasing. So
well, this is actually showing that as people they're likely to be diagnosed when they're younger. It has nothing to do with
again, age of diagnosis.
Yeah.
All right. And again, this is our just population numbers and burden of disease, and $7 billion probably could be spent better elsewhere. So what are we talking about as far as we've got a vaccine? We've had a vaccine for 10 years. It's evolved a little bit. We've got a better vaccine now than we did 10 years ago. And essentially, the vaccine is an excellent vaccine. The immune response to the vaccine actually is higher than the immune response to the actual illness. So this is as good as a vaccine can get, and essentially has close to 100% protection from the HPV types that are in the vaccine. So we've got this almost perfect vaccine. We've had it for 10 years, and we do a crummy job of vaccinating our children. We are still leaving half of our children unprotected. Yes, ma'am?
Bill, if people were vaccinated 10 years ago, and you just said it has gotten better, should people be revaccinated?
No, it's lifelong protection.
Okay, even the old vaccine?
Even the old vaccine.
Great.
Yeah. Now the old vaccine, there was two old vaccines. One of them only had the two most dangerous types. That vaccine is no longer available. Then the HPV-4 had 4, and for now 2 years we've had the HPV-9. The other two vaccines no longer are being sold or provided. So we essentially have one vaccine, but it covers all 9. But it's not recommended that people get re-vaccinated. And again, lifelong protection. This is as good of a vaccine as you can make. And so let me just kind of talk about how a vaccine works, just for a point. When you get the actual virus, the virus is a little bit of DNA or RNA wrapped in a protein coat. So the virus is this, British soldier wrapped in a red coat. What the vaccine is, we don't give you the British soldier. We just show you his red coat. Your immune system recognizes the red coat, remembers the red coat. If any soldier shows up with a red coat, you get out your musket and shoot him. So the vaccine is essentially just the protein coat of the virus, not the virus. But it educates our immune system. So we educate the immune system, we get good protection from those particular subtypes of the HPV virus. And again, the current one has 16 and 18 are the most dangerous, highest cancer risk. 6 and 11 causes genital warts. These other three improve that so that of the 100 or so HPV types, we're protecting against the 9 most dangerous. And timeline, initially we started in 2006, 2015 the 9-valent variety came in, and now the other two vaccines are no longer available. So it's recommended, it was tested down to from age 9 up to age 26. That was the cohort that was tested by the pharmaceutical company, so that's what it was licensed for. In practice, we vaccinate very few 9-year-olds. We tend to try to hit them as they're entering junior high school at age 11 or 12. That's the target audience. That's who we'd like to immunize. And but if we miss that window, we can immunize you really up to age 26. The issue is, once you've been exposed to the real virus and have the illness, the vaccine can't undo the illness. Can't protect you after the fact. And again, both males and females. But the marketing when this first came out was cervical cancer only. It was licensed only for girls, and that got embedded in consciousness. And so people think of this as a woman's only problem, and it's for both males and females. So for everybody, until this 2 months ago, for everybody it was a 3-vaccine series. When we catch you, then 2 months later, then 6 months later. And with minimum dose ranges, it has to be at least 4 weeks between the first and second dose, and it has to be at least 6 months between the first and the third dose. And I think I have a slide here so the new vaccine schedule, if you're young, the vaccine works better, you get a better immune response for younger adolescents. So for the younger kids, 2 doses are enough. The research showed that if we start you before you turn 15, 2 doses are enough to give you lifelong protection. So the new recommendations, now the recommendations have been passed through ACIP, which is the main recommendation body, and it's gone to the CDC, and it's not exactly official until the CDC publishes it on the MMWR, but that's expected sometime in December. But nobody believes that they're going to change gears. So the new rules were going to be, if we catch you before your 15th birthday, we can only give you 2 doses and you're fine. If we catch you after you turn 15, then you get 3 doses, then you're fine. If we don't catch you until after you've caught the virus, sorry. So essentially what we're trying to protect is cancer. We're trying to protect our children from cancer. The infection of HPV is asymptomatic. Doesn't give you fever, doesn't give you pain, doesn't give you itch, doesn't give you anything. But it sets you up for a cancer 10, 15, 20 years, 30 years later. And the cost of our negligence of not immunizing kids are we're going to lose more productive years. We're going to lose, we're going to have more cancers in women of productive age so that they may not be able to have children if we have to take out that uterus. We increase the angst, the worry, and the morbidity and mortality of an illness that is preventable. There's a lot of hype about safety, and essentially, we don't give you the British soldier, we just show you his red coat, okay? Vaccines are very safe, very safe. So we're giving you a protein. That's as safe as any other protein we give you. It's several thousand times safer than giving you peanut butter. Does that mean the hype and the worry goes away? Well, no. Our patients come in all scared about injecting something in their beautiful child. So we have to kind of help them deal with that. But in fact, we as providers need to realize that this stuff is as safe as anything that science can make. Now, vaccines are made by humans, so I'm not going to suggest that it's perfect. But it's as close to perfect as anything that humans make. It's safer than essentially all medicines. It's safer than most foods. Again, it's essentially perfect with an asterisk, like, yes, but it's made by humans. And so it's safe, and it works. In countries where this is well done, here in Utah, we immunize less than half. In Rwanda, by the time they got 4 years into the vaccine availability, they had immunized 92% of their teens. And I would suggest that maybe we in Utah could love our adolescents as much as they love their adolescents in Rwanda. The prevalence of the vaccine types, this is in Australia, they're already showing a herd immunity effect, that even the unimmunized children, unimmunized young women and men are less infected by this vaccine. Again, herd immunity works, and this is a contagious illness, so herd immunity works. And again, lifelong. So safety, again, vaccines are held to a much higher standard than any other medicines. That penicillin or amoxicillin they gave you was tested back in 1960, and then it was fine forever. It doesn't get retested. They don't check the batches. They don't check. They just figure that if it was safe back when it was licensed, it's still safe. Vaccines are continually have to go get through standards of the FDA. They continually have to go through safety standards. They continually have to go through efficacy studies, and there's a whole system of looking for problems. Again, safer than peanut butter.
Is it safe in pregnancy?
It's not recommended in pregnancy, but they had a pregnancy registry where for those women who were given the vaccine and became pregnant, they went back and they looked, and there was no problems. So they stopped the registry because it was so safe. They had no problems at all. But it's still not recommended if someone is known to be pregnant. All right. VARs and the data link, and these are essentially systems to continually watch for problems. I would say this is a painful vaccine. So the one problem we do see that's real is that if you do something painful to a teenager, they can faint. And so when we do this vaccine, not like a 5-year-old, give a painful thing to a 5-year-old and they just run out of the room screaming. But for a teenager, you have to make them sit there until they're not lightheaded. The vaccine isn't going to hurt them, but if they fall down and get a concussion, that could hurt.
When you say painful, so it's more like
Painful right at the site
that's what I'm saying.
for a few minutes.
Does it like painful just as they're getting it more than other vaccines?
It seems to be more painful than the tetanus vaccine that they get at the same time and the Menactra vaccine that they get at the same time.
A little more
But-
soreness after too.
But a little bit of soreness, but not really bad. You know, the student athletes still go out and throw the football just fine.
Yeah.
Oh, yeah, syncope. Falling over. So when it came out first new, there was a lot of reports, and the reports are often coincidental. You know, they get the vaccine one day and they get, you know, a headache 3 days later. And back when it was new, those were all recorded, and essentially those kind of reports have gone away just because it's no longer new and we no longer look for those kind of coincidentally associated things. All right, more safety issues. Essentially, they've studied this in depth, and it's all very safe. This was going back to the pregnancy risk, essentially found no real risk, and that they no longer are keeping track of that. Essentially, we now have 10 years of data, and it's presumed to be lifelong. There's no waning of the immune response, so it is presumed to be lifelong, but essentially those studies are still going on. So the impact on this, again, in Australia, thank you. In Australia, where they had a pretty good uptake of this, you can see it was introduced in 2006, introduced in Australia in 2007, and you can see the break in the improvement in protection. Now, one of the things that's interesting to look at here is that these are just genital warts, and that was an immediate response. Cancer is obviously 20 years down the road or 30 years down the road, so it doesn't have an immediate response as far as cancer, but you can sort of see the effectiveness of the vaccine against genital warts in an immediate change. Now, the other part that's important to watch here is there wasn't really change in the 30-year-olds because they were not immunized. And the biggest break is in the youngest cohort. These are the kids who got the vaccine. And these over 21 didn't get the vaccine, but there's a decrease there probably from herd immunity. And in the genital warts, and again, these are in the U.S., and again, we haven't had much of an uptake, so there really hasn't been a change. Couldn't we be like Australia? So the adolescent vaccine coverage rates, this is, well, we've got this great tool, but we're not using it well. And these are national data, and the top line is the Tdap. I guess I have a pointer here, and I will get out of the pointer. Top line is Tdap, and most states require that by law, and so we got 86% uptake. Meningococcal, a lot of states require that, some don't, but we've had a lot of uptake on that. And HPV is a little bit better than, this is first dose HPV, this is 3-dose HPV for girls, this is first dose HPV for boys, and this is 3-dose HPV for boys. We don't do such a good job. Here's a thought-provoking concept for meningococcal disease. Meningococcal disease is a very awful, traumatic, can kill you in a day kind of a germ. But its incidence is 3 per million, 3 cases per million. HPV's incidence of infection is 800,000 per million. We care a lot about those 3 per million here. We don't seem to care a lot about the 800,000 per million. Yes, ma'am?
Is there any benefit, if they get just 1 dose and don't come back for the other 2, does that give them any?
Yes, gives them partial protection.
Partial?
Yeah. And the data, obviously in the younger kids, the data clearly shows that if we can get them 2 doses, they get complete protection.
But there still is, so even the ones that just got the 1,
they're still good protection.
Still good.
Yeah, good protection, not great protection. But we shouldn't, we still want to do as good a job as possible to protect each child.
How much it decreases. Parents aren't they're going in to get the vaccines to start junior high, and then having to come back in on their own. For those other ones, you can just see that big decrease, and I wondered if it even.
As a parent, we should be embarrassed.
As a parent, we should be embarrassed. As healthcare providers, we should be embarrassed. We've got a great tool, and we're not using it well enough. And some of this discrepancy between initiation and completion is complacency. Some of it, as I mentioned, this vaccine hurts, and adolescents sort of have a say. But mostly this is complacency on the part of the provider and part of the family. And part of it is unbelief. Neither the provider nor the family may have any experience with HPV. The parents have had HPV, probably maybe of carrying it today, but they don't ever see it. It's, again, asymptomatic, and it's out of sight and out of mind. So if we did a better job, it's sort of easy to do a better job if you're only doing half. We could, all right, so these numbers are a little overwhelming. So there's 26 million girls under 13. 168,000 of them are on track to develop cervical cancer if none are vaccinated. And 54,000 are going to die if none are vaccinated. So we have lives to save here. And we've got a tool to save them. And there's a discrepancy between what we have available and what we use. So if, and 30% coverage, if we average boys and girls in our state, we have about 30% coverage. So if we're complacent enough to allow it to happen, we are saying that it's okay for 4,400 of these children, as they get to be adults, we're saying it's okay that they have cervical cancer. It's okay that these 1,400 die. I don't think anybody's willing to say that it's okay, but by our practice, by our actions, we are allowing this. This is immunization by state. And don't you wish we could all be Rhode Island? Here's Utah, third from the bottom.
And I think that's changed now, right, Dr. Cooper?
Yeah, the most recent data were state number 49.
Two from the bottom.
Yeah, with only one.
Arkansas beat us, and I think Wyoming is last. Who's last? Okay. So Kansas and Arkansas got their act together, and Utah and Wyoming are still trying to find their act. All right. So why should we care? Okay. Why should we care? Why should we care about these kids? So on our current trends, essentially you have to assume that 80% of these kids are going to catch this virus. And essentially a few are going to be lucky enough to avoid it by themselves. Almost all of the ones who catch this virus will carry it for a year or two and give it to someone they love. So even if they aren't unlucky enough to have cancer, they may give that gift to somebody they are intimate with. About 1 in 10 will die. 1 in 10 will develop genital warts. About 1 in 5 women, because of HPV, will endure 6 months of fear and worry about having that abnormal pap smear, having to get a cervical biopsy, having to worry about that, having to go back for more pap smears, carry that worry about their own health, carry that worry about what they're doing to their intimate partners, carry the body image difference of seeing themselves as Typhoid Mary, carrying this virus to the people they love. There's a lot of anxiety and worry during that 6 months until somebody gives them a semi-all clear. Intimacy issues, again, they are contagious. They are carrying a contagious virus, and so that changes their awareness of who they are. And about 1 in 156 women will develop cervical cancer, and a few will die. And here's the bottom line. All are preventable. All of this bad stuff doesn't have to happen if we just do our job better. And I'll move to the next slide as soon as the picture's taken. And so how do we improve this? Well, there's some reminder recall system. I'm going to talk now. I'm going to shift gears and talk not about the illness, but about what to do about it, and kind of provider possibilities for providers to do better. Reminder and recall systems. There's a lot of these. They're semi-effective, and you can have your electronic medical record nag you about it. You can have your nurse nag you about it. At the parent and patient level, the consumer level, we can do postcards and text messages and telephone calls. Standing orders, this is saying to your staff, the doctor doesn't need to be there to make the decision. This is a slam dunk. If they walk in, do it. and that covers the liability for the nurse to just do the vaccine if we have an opportunity. That helps. The provider assessment and feedback. This is, okay, I'm going to shift from the slides a little bit. I'm a pediatrician. I never deal with cervical cancer. I've never seen what cervical cancer looks like. I've never seen oropharyngeal cancer. I have to believe that they occur, and I have to believe that they occur in 30 years, so I protect this 11-year-old today. And that's hard to do. And so one of the things for providers is you just give them a score. You make it sort of a baseball game. You tell them what they did, and they, most providers are pretty competitive folks. They will try to get a higher score. So if we can give feedback about how well or how poorly they'll do, they will tend to improve their performance. And those systems work. All of these are in play in some offices in Utah. And we have a great immunization information system here in Utah. It will, if I call them up, it will tell me what my office rates are. None of these have gotten the job done in the last 10 years. So all these are tools, but the tools have yet to be as good as we would like. And these are just some statistics about if you do a reminder recall system, you can improve your performance, by 9% here, and 15% here. So they do work. They just don't work well enough and complete enough. All right. So again, as a provider, the part that I've tried to figure out is how do we communicate the need for this to a family who doesn't understand it, to a child who doesn't want it, to a provider who's never seen it. How do we get the communication part so that it's immediate and relevant and urgent? So, evidence-based messages. This is giving people data. So this is cancer prevention. And it's not about sexuality, really. It's just about cancer prevention. And that cancer is going to be an issue in their lives if we're not. The other thing is the immune response of a young teenager is better than after they've gone through puberty. So that if we can immunize them before puberty, they are going to have better lifetime protection from that vaccine. It works better. And then the other part is, not only do we have to start, we have to finish the game. And right now, if we start early, we can do that with 2 vaccines. So health care professionals should. So I have a patient that comes in, and I got 15 minutes to assess their development and assess their growth and answer the questions and figure out why they're not sleeping well for their mom. And I have to do all of this other stuff, and yet I still have to keep this in mind. And so, healthcare professionals should be aware of the indications. Yeah, they are. And they should make strong recommendations. Yeah, they don't. And be aware of and interested in the systems that can improve the practice of a vaccine. They don't feel much urgency about this. The doctors, again, don't see it. They don't, they don't feel much urgency to get the job done today. So we have a lot of work to do. So one of the things that has happened, and this is research in the pediatric literature, is that doctors do this. They say, oh, he's going into junior high school, so Jimmy today needs a Tdap and a Menactor shot, and and we ought to talk about that HPV vaccine. Okay, right there, just body language and message, I've talked them out of getting the HPV vaccine. I've made it special, different, optional. If instead I just said, hey, he needs 3 vaccines today. It makes it normative, it makes it obvious, it makes it complete, it makes it simple. They came to me because they trust me a little, and I, in using my trust, said, yeah, this is important, this is what we're going to do today. Notice I did not talk about whether or not this 11-year-old boy is going to be sexually active tomorrow, because it doesn't matter. He's going to be sexually active sometime, and we got to protect him today. Now, doctors, being humans and part of our society, also have mixed emotions, negative opinions about whether this is a new vaccine. Well, it's been 10 years old. It's only as new as the Menactra that they use all the time. It's not new. It's not unstudied. It's not, but again, it doesn't have any urgency for them, okay? Because they've never seen the consequences of not doing it. And providers are also distracted by the sexual issues, okay? The provider doesn't want to talk about sexual activity in an 11-year-old either, okay? The parents don't, the child doesn't. The child is mortified, and both the parent and the doctor are uncomfortable about it. But it's not about that. It's about cancer. And then when parents expressed reluctance, providers were hesitant to engage in a discussion. And the parents might have said, ooh, I don't know. And the doctor said, oh, you don't like it? Well, we'll move on. Well, it could be that they just need a little bit of information. Could be they just need a little emotional push. Could be that the doctor just needs to stand up and say, hey, you know, this is important. You know, I want to protect your child. That's why we talk about bicycle helmets, and that's why we talk about concussion on the soccer field, and it's why we talk about vaccinating them, because I also care about your child. I don't want your child to have to go through this agony. Some providers share the parents' view that their child was not at risk for HPV and could delay the vaccine until the child was going to be sexually active. But turns out that we don't know. You know, it turns out that there's a lot of sexual activity in teenagers, and that we can't know when he's going to be vulnerable to this illness. So I'm going to move through these a little bit because I want to talk more about. So a strong recommendation. I'm your doctor. I'm Jimmy's doctor. I care about his long-term health, and today I have an opportunity to protect him from cancer. Done. So if you recommend it, it's all in the same way. Again, it makes it normative. It's not a special vaccine. It's just one of the vaccines that we have in our arsenal to protect your child. And I'm going to skip through these. And cancer prevention, there's a little bit of trouble there. Cancer is a scary word. So when I say cancer, their fear goes up. If the fear goes up, their ability to take in new data goes down. So I have to kind of talk about this kind of gently. So, and this is CDC's recommendations. I tend not to throw the cancer word around very much myself because, again, it's fear. All right, and so if we wait, we run the risk of this. The average time of sexual initiation in our country, Utah might be a little different, is October of 10th grade. Half done by then. So, and this is such a pervasive pervasive illness, that very many of the victims of this infection catch this infection on their first encounter. Also, they don't actually need penile intercourse to get this. Half of college women were positive for HPV 2 to 3 months before they actually had vaginal intercourse, just because of other skin-to-skin and mucosal interactions leading up to that. So again, you can't wait, or you're going to not protect them. And I'm going to talk. I'm going to get down. Research has shown that this does not increase sexual activity in our teenagers. They already know the secret about sexual activity with or without the vaccine. Those decisions are made in some other arena than in the pediatrician's office, so we need to protect them. So, too young, essentially, the other sexual activity is happening earlier and earlier, and I'd fix it if I could, but I can't, and so we need to protect our kids. And the other thing about exposure is says, well, let's wait until she's older, and that essentially the time, there's a sense of urgency that the provider needs to have about this may be the only time I see this child. When kids get to be adolescents, they only come in for, sprained ankles or whatever, and so personal belief. One of the strongest recommendations for pediatricians or providers is to say, well, I did it for my child. Because that cuts right through the safety issue, cuts right through the issue, cuts right through the issues of whether or not this is permission for sexual activity. It says, hey, your child, for my child, this was important, and I think it's important for your child too. So that cuts right through a lot of that stuff. And then just say that you strongly believe it and act like it. Now, side effects are minor. I'm going through this an awful fast. I have a lot of slides. And I want to get to, this is just completing the series. And, okay. So, selling the vaccine. So, the doctor, the provider, the nurse is a salesperson. That's not a job we're trained for. And as a salesperson, or even as a communicator, the first thing you have to do is understand where your audience is at. And that's tricky in this. We've got, they talk about the millennials, okay? The parents of this 11-year-old are in the age group of, I don't need no experts, I got Google. They're not as willing to just accept my word for it. So I have to use other sales techniques to get the job done. And this is one of the things that's been studied, but I don't tend to use it myself. So first, know your audience. Do they just have a knowledge gap, in which case a little bit of information is all you need? And the one thing you have to do when you give them information is you have to honor them. They're not supposed to know about HPV prevalence and infectivity. They're parents. They're supposed to know how to protect their child. Recognize and honor their fear is a good thing. If they weren't fearful about their child, they're not awake. And we have to honor their fear and accept their fear as an appropriate response, and then walk carefully around it, and I'll maybe have a time to talk about that. And then, so our job is to motivate them, and that didn't work. I don't know what happened there. I'm going to go back. So the conspiracies, about a third of the parents are just leaning information, and a third are about fearful of stuff, and a third believe that doctors and the government are in collusion to harm their child. And these are folks that are hard to deal with, but if you understand where they're coming from, you can kind of help them. So the goal of this group is they need to be in control. So if I act like the expert and give more information, I'm just convincing them that I'm part of the conspiracy. So their mission is summed up by, you can't be the boss of me. And so they don't trust experts, so acting the expert doesn't work very well. Did it again, all right. So essentially in this generation, they seem to be convinced by the numbers of likes on their social media stuff, somehow gives them permission to believe this or that. But my goal is, I just stop. I just say, okay, there's a risk out there. How would you like to protect your child? And then I do that. I just shut up. because the silence is very painful for all of us as social beings, and they have to fill up, they have to say something, and you just let them talk and let them talk themselves into this is the only way that's possible to protect their child. They already know the information. They've read all those websites. They know the statistics. They know the stuff. They just can't get themselves to convince themselves. So you let them convince themselves. You try to get out of the way. And summary. Let's see if I'm going to give a strong recommendation. If possible, give them a personal story. Welcome their questions. If you can get into a conversation, then that gives you an opportunity to improve the odds that they will get the vaccine before they walk out there. A lot of good information, cdc.gov vaccines, you are the key. There's a paper right here that you can take, and very good information. And the one thing, let me summarize, and again about the salesmanship. What I've noticed is that it isn't exactly what I say that makes a difference. If I walk into that room ready for a fight, I'll have a fight, and sometimes I'll win. If I walk into that room with a gift to give that child, I almost always get the job done. So, and what does that mean? It's probably body language. It's probably how my confidence in the vaccine. I've already dealt with any fear issues, so because they're fearful, I don't have to be fearful. And that fear is a communicable disease too. So early in my career, if they were fearful, I was fearful, and then the conversation never went well. So, but I walk in confident that I have a gift to give, and then it works easily. Now, I welcome any questions. Yes, ma'am.
Why is this vaccine not a requirement for schools and stuff? You know, like when I take my kids in, I have to have these ones. Why is it just out of curiosity? Why is it just a optional? What would make it so it would be required?
Because it's not contagious in the classroom. Now, it is contagious out in the back parking lot, but it's not contagious in the classroom. And there's this, as soon as the vaccine came out 10 years ago, Texas made this mandate, and there was such a flare-up and pushback that it lessened the vaccine's credibility throughout the country. So really, none of us advocates are pushing for that, partly because if we make them do it, then it becomes sort of negative. So, so that's why it's not required.
And there's a few states that have tried, like Virginia, Washington State, they haven't, Washington, D.C., they haven't been successful.
Yeah, it hasn't changed.
What's been successful is Rhode Island, but there's a very small, homogeneous type of environment. And
Yeah.
that's just recent data.
Yeah. But mostly it's a political issue because of the sexual transmissibility of it is a thing that no school district wants to deal with, and certainly no state legislature wants to deal with. So
I have a small question and a couple bigger ones. The small question is the data about communication with families. If there's data that says that if the physician is confident and firm, and that increases the likelihood of immunization. The anecdote I've heard is the influence of the MA, or the front desk person, and where if walking the patient back and the mom says, well, what do you think about this? And the MA says, oh, hey, you're toast.
Yep, you're toast. You lose the game. Yeah. Yeah.
So does that,
Yeah.
Is there data about that?
I have not read any data, and I've experienced it in my own office, and I've done a couple QI processes, quality improvement processes about vaccines, and you need the whole team. You need the person who makes the appointment needs to say, hey, and bring your shot record with you, and we'll make sure your child is up to date on everything we can prevent. The MA has to be a believer. The doc has to be a believer. And again, it takes the whole village to get one child vaccinated. And one little slip up means it isn't going to happen. So I've not seen any research about it, but it's a real thing. And unfortunately, MAs are there's a lot of turnover in that, so that it's hard to keep the zeal going in an office, because it takes zeal.
The scientific question is, let me say I'm a true believer, and I had my kids vaccinated. So.
Well, thank you for that.
But there is some pushback among legitimate scientific conservatives who say that the evidence is preliminary, it's intermediate variables, it's not the outcome of cancer in the United States or reduced death rates, and therefore it's premature.
Let me see if I can phrase that so that we get this on tape. There is some pushback among the scientific community that the final outcome of preventing deaths is not yet available, and that's because there is the average is about 20 to 30 year delay, and the delay for the actual cancers to show up could be 40 years. So we can't wait and waste 40 years of cohorts of children while we're waiting for the perfect answer of, does it really prevent cancer like we think it should? All of the preliminary data suggests the incidence of abnormal pap smears, the incidence of pre-cancerous changes, all have shown decreases that indicate that we should believe that we will see decreased deaths when enough time has elapsed. And yet, perfect, pure science is you wait until all of the data is in, but waiting 40 years for the data means 40 years of birth cohorts that are doomed to these cancers. So the science has to be metered out with a little bit of common sense. Great question.
Yeah, I mean, I have respect for the concern about intermediate variables versus outcome variables. You know, I trained in the area of Swan-Ganz catheters, and we spent an awful lot of time putting in swans and people in ICUs, and only later, because it made so much sense.
Mm-hmm.
And the intermediate variables of cardiac output control and so forth were dramatic, and then we found out we were killing people. And then it's reasoning by analogy, but I think that there is reason to be respectful of that. I happen to think that the intermediate variables in the pathway toward cancer of cervix or other are robust enough so that addressing those intermediate is going to be reducing the end result. But I think that's the debate.
And it's a good debate, and the nice thing about all science is that all scientists are skeptical. They don't trust today's data, and they go after tomorrow's data. And I think that's clear in this. I would not tell you that we've got the best vaccine possible. I'm not going to tell you that it's going to work perfectly. But I do think that right now it's the best gift we can give to our adolescents, and we ought to give it to them.
So my third issue, and sorry to be taking over.
They're going to cut you off.
The third issue is we're sitting in the Southwest Utah Health District.
Where there are pockets of conservatism, and this area has some strong beliefs that that we shouldn't protect children from illnesses that are somehow related to premature sexual activity. And my own belief is that I would love it if children did not engage in dangerous activities until they were adults. And near as I can tell, adulthood starts when you're about 25. And yet the apparatus for sexual gratification is there when you're 13 or 14. So we're asking our adolescents to fight their own nature for 12 or 13 years. And I support all of the efforts to help them make rational decisions and moral decisions and ethical decisions. But I have yet to meet a perfect adult, and I have yet to meet a perfect child, and they're going to make mistakes. I just don't want those mistakes to cost them their lives.
Yeah, I'm going to try and channel your language. Thank you.
Okay, can I summarize one thing?
I just want to say.
Yes,
really
we're out of time.
Yeah, we're out of time. We've got just a few minutes left for the break, so if you still have a few questions, but we will be having some other people.
All right, and I'm going to summarize one thing. In terms to make this real, because I don't see the cervical cancer, what I do to keep myself enthused is I have it in terms of just some numbers. If I immunize 5 girls, I protect one of them from an abnormal pap smear and 6 months of hell. If I immunize 10 children, I protect one of them from genital warts. If I immunize 156 women, I protect one of them from cervical cancer, and if I protect 500 or 600, I protect somebody's life. Now, I don't know which is which, so I'm not going to get a thank you note for that one whose life I saved, but it helps me keep it real so that I can do this job and stay feeling urgent to get the next child immunized. I thank you for your time and attention.
Thank you.
You know, Bill, it's not about sexual activity.
It's not.
Because as you say, almost every, I'm willing to accept that there are some exceptions, but almost every 13-year-old child will at some point in their life
Right.
engage in sexual activity. All you're doing is protecting them early
Right.
and better for the inevitable activity. Because, I mean, even as a conservative, do I honestly believe that my virginal children will only interact with virginal children?
Right.
I wish I could say that
Yeah,
that's true.
because even if your daughter makes only perfect choices for her childhood or her life, if she's perfect, she still has to have the luck of finding a perfect life mate, and you know, so I mean, essentially the odds of 2 perfects coming together are kind of low.
Well, you convinced me.
Okay, good. There's that one.